Now, guys, it is a great pleasure. The guy who is the pimp daddy, granddaddy, and when you say the word carcinoid, the first thing that ought to come in your mind is Richard Warner. Dr. Warner has always said to me that he would be the guy who would kick off this conference. He is what defines the penultimate carcinoid guy. He knows it all, he's done it all for 40 years, and he still is out here taking his time and effort to come, and he is just the cat's pajamas. If you don't know Richard Warner, you need to know him because he knows everything there is to know about neuroendocrine tumors. Richard.
Thank you, Gene. I'm embarrassed and nervous after such a superlative introduction. How can I possibly give a talk that'll live up to the quality of that introduction? However, we'll try. Good morning, everybody. I'm pleased to see you all. And I'm also interested to see the magnitude of people attending this meeting. That certainly goes against the concept that carcinoid and related neuroendocrine tumors are rare diseases. From looking at the numbers here, we would think that they're not so rare. However, we do know that really, in general, that is the case, and so progress goes very slowly. But yet, there are other diseases that are less frequent, and they get more attention. For example, the usual cancer of the pancreas or cancer of the stomach. Actually, the number of new cases that develop or are reported every year is less from the combination of those two, less than the number of new carcinoid or neuroendocrine tumors. It's just those people die quicker. We have a slowly progressing disease in general. Now, what I'm hoping to do today in this introductory talk is to review the basics for those of you who are new to the disease, and also update for those of you who are medical or knowledgeable veterans of the disease. You're a very mixed group, and I can talk easily over the heads of those who are newbies, and yet rehash the old stuff that those of you who are veterans know about. We're going to try to make this useful for both groups of people. And here we have listed the frequencies with which these diseases occur. I would point out that of 100% of neuroendocrine tumors, 75% are carcinoids. That's why we hear so much about them. They're the lion's share of these tumors. 25% are related non-carcinoid neuroendocrine tumors, and the bulk of those arise in the pancreas, and so they come from the various cells of the so-called islet cell group, and that's why they're often called islet cell neuroendocrine tumors. We'll talk very briefly about those. They are comprised of a variety of different types. They may be non-functioning, that is, they don't produce enough of any hormone to cause a syndrome, and that's the majority, the largest single group. They may produce insulin, and so they're called insulinomas after the substance they produce, and can cause symptoms due to low blood sugar, just as if a diabetic had taken an overdose of insulin. There's also a group called gastrinomas that make an excess of gastrin that cause a very bad stomach ulcer disease and may cause diarrhea and rarely even flushing, and sometimes the diarrhea occurs alone, so that there's an overlap. Then there's a group called vipomas that produce VIP, a hormone that stimulates the intestine excessively, and profound watery diarrhea characterizes that particular type of tumor. Glucagonomas produce glucagon, which is a substance that is the opposite of insulin. It causes elevated blood sugar and severe diabetes, plus other symptoms. Somatostatinoma is a group of tumors that make an excess of somatostatin, and that causes gallstones and large tumors. And then there's a wide number of various other neuroendocrine tumors that can produce almost any hormone we know of. They're all quite rare. But on back to the carcinoid itself, that comprises 75% of all meds. Most of them, 2/3, arise in the gastroenteropancreatic system. Those are predominantly in the small intestine, but can occur anywhere in the gut. 28% are developed in the lung, bronchial carcinoids. But then there are a number of other really unusual places where they can develop: kidneys, breast, even the pancreas and the ovaries. So that the symptoms can be widely varied depending upon the site of location and the hormone being produced. And here we just see the same thing as I've just said, described graphically. Now, in a review of over 35,000 cases completed from data obtained in 2004, it was found that over the last group of decades, every single decade saw a doubling in the number of cases. Not because we're having an epidemic of carcinoid or neuroendocrine tumors, but because there's an increasing awareness, but it's still not good enough. Also, now we have a bit over 5 new cases per 100,000 of the population every year. And since most of these patients live, as you saw today by those who stood up, live for quite a long time, and in fact we don't know really quite how long, because we have newer treatments that seem to be prolonging survival. We therefore have well over 100,000 people of your type walking the streets of this country, and that are known, and probably twice as many that because of those that haven't been reported or are unknown. Now, an analogy. Canines, meaning dogs, they all belong to one family, the canine family, but yet they're different breeds. They're all different. So no one management will fit every single dog. Similarly, carcinoids all belong to the neuroendocrine tumor family, but they're not all identical. One treatment doesn't work in all cases, as you all know. It has to be designed and customized for the needs and particularities of each given case. And that's part of what you're going to hear today in all the talks that will follow. All the different things that are available, that are new, that are under development, and so forth. A very important thing to realize is originally carcinoids at the turn of the 1900th century were thought to be practically benign, and that concept of almost benign has hung on, unfortunately, and therefore many oncologists, general physicians feel that it doesn't deserve serious consideration, but rather wait and see, watch. It may take a long time before any symptoms develop, and unfortunately, by the time symptoms develop, these tumors are usually quite spread and far advanced, and the results of treatment are not as good. As you see, over 50% or even more will have spread when first diagnosed. In a good number of cases, I'm sure exemplified among people here, are found accidentally in the course of some other examination or surgery. So we need to get the word out for awareness and therefore make earlier diagnosis. But because of the fact that things can be done, the pendulum of therapy is swinging towards a more aggressive approach, and the wait and see doesn't hold anymore. Now, we are entering a new era, the genomic era in medicine. That means that we're getting better understanding of the role of genes and what they do and how they're comprised and what to do in terms of treatment. Here you see some monstrous big pumpkins, the result of genetic mutations. And similarly, everything that's living is dependent upon their genetic composition. And as we learn more and more about the genetic composition in neuroendocrine tumors, we get better able to apply new treatments. And today I will very briefly review some of the genetic mechanisms for you. The other thing I'm going to do besides reviewing in general the features is I'm going to give a little bit of the talk on the mechanisms of diarrhea, since they're so common and can be widely varied, and the treatment depends upon understanding what's going on. It's not just you eat and it goes through you quick. There are other things involved. So first, on the genes and the chromosomes, the genes are really the coded messengers in a cell, and they direct what the blueprint of what's supposed to happen. And they're all gathered together in chromosomes. Now, I don't want to get too technical, but the chromosomes are long molecules that are made up of DNA, deoxyribonucleic acid, and they're like a ladder. There's two strands of this material, and they're joined by what would look like rungs of a ladder, and then the whole thing is twisted into a spiral, so it's called a double helix. And this comprises chromosome there, and the structure of the rungs, they're called, is made up of pairs of 4 bases. And I won't bother you with the names, but they're known by their letters A, C, A, D, G, and C. And how they match up to will make each one of those rungs. And they're like the letters of an alphabet. Their order spells out what letter they are, and the sequence in which they come makes a word, and then the way they're strung along makes a sentence. And these are the sentences that dictate every single function in every single cell in an individual's body. And there are some 30 to 60,000 genes in the human person, and knowing and mapping them all is called genomics. And this has been accomplished for the human body, so we know the blueprint for all of this. And when there's an error in the placement of 1 or 2 of these, then that's a mutation. And some function may be thrown off. And actually, every human being may have as many as 60 such variations, such mutations. But like the letters in a sentence or in a paragraph, sometimes the mistake doesn't change the meaning, and you can make out what it says. Sometimes the body can just pass over that. Sometimes a mistake changes the meaning, and then an important enzyme or something else in the body doesn't work right, and a person develops a cancer or develops some other disturbance in their body function. We're learning about that. We're learning how to take advantage of that and how to diagnose. And in the body, there are a total of 46 of these chromosomes. The chromosomes are made up of these double strands of DNA. And the genes, just to look at it more simply, are like beads strung along, or different kinds of beads in different positions, beads of different size, strung along the length of that necklace, if you wish. And so we get 23 from our mother and 23 from our father, and together it makes 46 of these chromosomes. And everybody has that. Now, among the various things that happen in the 10, or more than 10, 300 zillion cells that you have in your body, is that they're all reproducing themselves, replicating, but they're not doing it every minute of the time. There's a cell cycle during which the cells are replicating. The DNA is divided into two and passed on to two cells, so each single cell makes two more, each two make 8, and so forth. And that's during the act of replication. But then there's a resting phase too, when nothing is happening. Most of the chemotherapies that we know attack the replication phase. And since these tumors are usually slow growers, their replication phase is not very active, and only a small percentage of cells are vulnerable to such treatment at a given time. Now, I mentioned about the errors that cause the mutations. And the body can correct some you're born with, and some are acquired. And as I said, they're not all serious. Some can be. Now, here you see a representation of normal cell division, and then the uncontrolled growth that represents cancer. The normal cells also die off. That's called apoptosis, and that scheduled or programmed death of a cell and then replacement by new ones is normal. But in cancer or malignant tumors, those malignant cells don't die off. They just keep replicating. That's why a small cell that gives rise to, say, a carcinoid keeps on growing and doesn't die off. Now, some terms that are important. Mitosis is the process by which these cells replicate. And if we do special stains or look closely at the microscopic appearance in a biopsy, we can identify how many cells are undergoing mitosis, because you can see the change in the chromatin material in the nucleus of the cell. And you see in this picture the circled cells where their nucleus stands out different than the other ones. And then we can do other special stains for Ki-67, or also known as MIB1, and that will show us changes in the protein in the nucleus that tell us these cells are in the process of or going to be able to replicate very soon. And these tests, both for a mitosis count and a proliferation count, that is how many cells show Ki-67, these will help determine the aggressiveness of any given tumor, and they should be included in all biopsy reports, all pathology reports. And I think you're going to hear more about that shortly as we go along. Now, in terms of inherited disease, inherited neuroendocrine tumors, this is quite rare, but it occurs in somewhere approximately 4% of all carcinoids. The most well-known one is the MAN, multiple endocrine neoplasia type 1 syndrome, and you will hear about that later. Less common is von Hippel-Lindau, which is associated with a variety of vascular cancers and often pancreatic neuroendocrine tumors, or sometimes kidney cancer. Neurofibromatosis type 1 is associated with brownish spots on the skin and little fibrous growths, and also sometimes with special neuroendocrine tumors. Another very rare disease, tuberous sclerosis, also is associated with a genetic abnormality that causes neuroendocrine tumor. And finally, familial carcinoid, which is under study at several centers, particularly at the National Cancer Institute at present, has not been well understood, and the genetic abnormality associated with it is not known yet, but people with this will have other family members with carcinoids, and not so much other neuroendocrine tumors, just carcinoids, and usually mid-gut carcinoids, and that's actively being studied. Now, on to characteristic things. Here we see a piece of intestine that's been split open, and you see the little nodules. These are multiple small primary carcinoid tumors, and this is quite characteristic. And many of these carcinoids, at least 25%, are multiple, don't occur as a single isolated tumor. They develop under the lining of the intestine. Here in cross section, you can see the yellowish tumor, and if you look at the bottom part, you see streaks of that going through the muscular coating and all the way out to the serosa at the bottom. That's the lining of the outer surface of the intestine. So this harmless little lump is actually a malignancy that is spread through the full thickness of the intestine and has to be taken out totally. It may stay like this for a number of years, but spreading silently. What are the commonest presenting features? Well, for mid-gut carcinoid, which is the most frequent location, pain. The pain may be slight at first and misdiagnosed for many years. Commonest misdiagnoses are irritable bowel syndrome. I'm sure there are many in this audience who had that diagnosis initially. Or Crohn's disease, inflammatory bowel disease. And then only later on, intestinal obstruction, or less commonly bleeding, or other symptoms occur. And some people don't show up until there's a mass. They feel a lump in their belly, or the doctor feels it at a routine exam. And a few first come to attention when they have symptoms of carcinoid syndrome, such as flushing, facial flushing, or uncontrolled chronic diarrhea. And then a fair number are just found accidentally, coincidental with a surgery for a gallbladder, and lo and behold, there's tumors in the liver, and the gallbladder diagnosis was wrong. Now, for lung carcinoid, that comprises a little more than 1/4 of all the cases, it's often a coincidental finding. I see it in patients who have a chest x-ray taken before some routine surgery for some other purpose, and a small rounded shadow was seen somewhere in the lung. So this was an accidental finding, and it's more important often than the purpose for which the x-ray was taken. Or a person may have a recurrent pneumonia, always in the same segment, because of blockage of the bronchial tube by a growth there. Or they may cough up a little bit of blood, or may just have a chronic dry cough, or may show up because they've got an enlarged liver due to distant metastases. Occasionally, the metastases may be in unusual locations, like the skin, or in the breast, for example, or even a mass in the pelvis. And finally, again, the syndrome, an endocrine syndrome may be the presenting feature. And lung carcinoids can have a variety of syndromes, not necessarily carcinoid, even one called Cushing's syndrome, which I won't go into description of right now. Now, carcinoids represent only 2% and other nets of all the gastroenteropancreatic malignant tumors. Colorectal cancer, adenocarcinoma, much more common, 10 times or more. And same thing holds for pancreatic lesions of other types. These tumors, the carcinoids and NETs, can be functioning or non-functioning, as I said before. Microscopically, all the different carcinoids and NETs look pretty much the same unless special stains are done to determine just which they are, and the stains have to be for the products that they make. For example, a gastrinoma on biopsy may look pretty, by standard H&E stain, may look to the pathologist just like a carcinoid of the midgut would look. There is, as I said before, a minimum of pathologic data that's required and should be given on a biopsy. This is not commonly the practice except in major centers, unfortunately. And doctors should insist upon all of this. They've got to know where the tumor came from. They've got to know what the grade of malignancy is according to a standard formula. They've got to know what the mitosis index is that I referred to, what the proliferation index is, and then the final diagnosis of what it is. And there are special stains to help with this, as I've indicated. And then finally, there's a staging, TNM. This classifies the degree of extent of the tumor, that's the T, whether there's lymph node involvement and how many, that's the N, and M, whether they're distant metastases and how much. And you'll hear more about this later. Now, the prognosis depends on where the tumor arose. Therefore, it's not enough to just diagnose by a needle biopsy that you got metastases in the liver. We'd like to know where it arose because that has a strong influence on what you can predict will be the outcome and also even on choice of treatment. If the primary tumor is small when diagnosed, that's better. If it's bigger, that is 2 centimeters or more, there's a much greater likelihood of spread. In fact, in the intestine, if it's 2 centimeters or greater at the time of first diagnosis, there's better than a 60% chance that spread is present. The actual pattern, the architectural pattern of the disposition of the tumor cells is important too, and therefore a fine needle aspiration biopsy is not nearly as good as a core biopsy, and a regular open biopsy with a good piece of tumor is best yet. However, in terms of the carcinoid syndrome, patients with the syndrome, if it's untreated, do much worse than those without. But nowadays, most people with syndrome are treated, and their outlook is just about the same as those without syndrome. But again, there's a wide variation, like the picture of the multiple different types of canines, the different great variety in carcinoids, even in those that look the same. Consequently, the treatment may vary and has to be customized in each individual case and is best handled by experts. They usually are slow growers, as I said. In the small intestine, about 1/5 will metastasize. I referred before to the size of the tumor being related to its aggressiveness. I mentioned that they're often multiple from the small bowel. And the carcinoid syndrome is in a minority of cases, less than 40%, and usually require liver metastases. The syndrome itself consists of facial flushing, which is usually dry, at least at the beginning. It's not like a menopausal hot flash, which is moist. The diarrhea may or may not accompany it, or sometimes may be alone. It's usually fairly painless. It's usually quite watery and without bleeding. There's a deficiency, vitamin deficiency disease due to a lack of niacin called pellagra. We don't see that much in this country because our food is often fortified with extra niacin. But in tumor-making serotonin, niacin becomes deficient because they both derive from the same origin, tryptophan. And if the tryptophan is being gobbled up by the serotonin-making tumor, then niacin deficiency occurs. And with niacin deficiency, the symptoms are diarrhea. And you don't need that diarrhea on top of the diarrhea of carcinoid syndrome. In addition, we can get dementia, mental changes, and we also get skin changes, pigmentation, and so on. This is all relieved by taking supplemental niacin, and it doesn't have to be in big doses. Venous telangiectasia, little spider vessels on the face, occur after a long time flushing and persist even between flushes. Bronchospasm, like asthma, may occur. Heart manifestations, namely, there are 3 different types. Tumors may actually spread to the heart or the pericardium. That occurs in about 5% of cases. We may just simply have no anatomic changes in the heart, but overstimulation of the heart by the hormones being produced by the tumors, and so eventually heart failure on that basis, or classical valvular disease, usually affecting the right-sided valves, tricuspid and pulmonic, but there are exceptions when the left-sided valves are affected. And finally, the cause of metastases, enlarged liver is common. There are a group of minor symptoms that you see there. Very frequently we'll have peptic ulcers. We may have low serum albumin, wasting muscles, joint pain, and in certain, particularly lung carcinoids, we may get a funny type of edema. It's discolored, brownish, and also persistent and not soft where you can press and bit the swollen legs. And then finally, hyperglycemia. A patient with diabetes will have worsening of their diabetes, or a patient without diabetes, if there's a family tendency, may develop it as a side effect of carcinoid. Now, these features also can be worsened, at least the diabetic tendency, by a treatment with octreotide, but they're controllable with the usual diabetic medications. And here, a picture of flush for those who may not have seen it. Is a gentleman very uncomfortable, and I might add, all these pictures were, of course, with the permission of the people who were photographed. And you see on his upper chest where fingertip pressure before the picture blanched the skin, so he's quite red, particularly across the nose and the cheeks. And he's uncomfortable, you can see that. And here, after the flush subsides, he's feeling better, but he's still somewhat red. This is a far advanced characteristic case. Here's another gentleman who, on the bridge of his nose and his cheeks, has the telangiectasia, the little spots. Many other diseases will cause that too, but sometimes that's a tip-off on the diagnosis. Now here's a gentleman very early in the course of the syndrome. You can see the slight reddening of his cheeks, just the beginning flush. That doesn't mean everybody that has a little flush like that has carcinoid, because some people are born having red faces. Some people will get that from other things. Try eating too much hot mustard, and you may get red in the face like this. Now, there is such a thing as carcinoid crisis, and that deserves consideration. This is a severe exaggeration of carcinoid syndrome features. It often occurs during surgery or anesthesia or stress of some sort or another, and may be accompanied by severe vascular collapse. Anybody who has carcinoid syndrome, or even carcinoid without syndrome, but in whom there's known to be elevated blood serotonin or urine 5-HIA, should be treated prophylactically with large doses of octreotide before and during any significant surgery or even dental procedure to avoid carcinoid crisis. Very briefly about diarrhea. The intestinal tract secretes vast amounts of fluid, maybe 9 liters a day. I won't go over the exact numbers from different parts, but saliva, stomach secretions, biliary secretions, pancreatic secretions, small intestinal juice, so on. It's all reabsorbed in passage through the intestine and the colon, so that in spite of all of that fluid that we secrete internally, as well as what we drink and in our food, only 1 or 2 hundred cc end up being excreted as fluid or stool water. And if we have an infection that irritates the lining of the intestine, we may get an increased secretion, we may get impairment in the absorptive surface, we may have a shortened intestine so that we can't absorb as much of this material, we may have tumors that produce hormones that provoke rapid passage through the intestine. There are many, many mechanisms which can cause diarrhea, and there are different types of diarrheas also in terms of what the content of the stool is. So they're not the same, and to know best how to handle any given case, all these factors have to be taken into consideration. And for example, carcinoid diarrhea does not always respond to standard antidiarrheal medications. Now quickly, because my time is almost up, in diagnosing carcinoid, the first and key thing is being suspicious. You got to think of it. So when you hear hoofbeats, it's not necessarily a herd of horses. There might be a zebra there. The unexpected rare thing has to be considered, and so you must think of it. If you think of it, include it, and I'm talking about the doctor, then he can do the appropriate tests. We can check for the markers. We can check thereafter for imaging, that is x-rays or scans, and then finally prove it by biopsy. The markers most commonly used are the urine 5-HIAA, and now we have a new test for it in the blood, and you'll hear about that today. Serotonin, or blood serum serotonin is not tested as often as it should be, in my judgment, and it's universally available. And chromogranin A also is considered one of the gold standards, but it's not specific. It's elevated in most of the neuroendocrine tumors, but more than that, it's thrown off and falsely elevated in patients who are on a PPI, the proton pump inhibitors, which many patients are on, and just stopping for a day or two is not good enough. You have to stop for weeks to let the values go back to normal. Then there's also pancreastatin, which is very good and not thrown off by the same things that influence chromogranin A, but it is not universally available and often not covered by insurances. And the same thing holds for neuron-specific enolase and substance P. Some of the other markers you see listed there, the CEA, which is very commonly elevated with colorectal cancers when they've spread, is rarely elevated in neuroendocrine tumors, and when it carries a very bad outlook. And here is just listing some of the areas, some of the conditions in which chromogranin A is erroneously elevated. So there are many situations in which that may be the only thing found elevated, and one has to be careful how much credence you put in it because of these other possibilities. The standard imaging techniques, of which you'll hear more about today, are standard X-rays, CAT scans, MRIs, ultrasound, isotope bone scans, but the gold standard at present is the Octrio scan, gallium-68 scan, which is eventually going to replace the Octrio scan, is just beginning to come to this country, and it's still experimental. It's been in use for at least 10 years in Europe, and is perhaps 10 times as sensitive as the Octrio scan. The standard PET scan, FDG, fluorodeoxyglucose scan, is not so helpful for the average carcinoid or neuroendocrine tumor because it's dependent upon the aggressiveness of the tumor. If the tumor is indolent, as most are, it may not show up at all. So it's not a good scan to diagnose. It'll help to tell you how aggressive the tumor is. And this is just an example of Octrio scan. And you see in the liver, which is a large gray structure on the right-hand side, these dark spots, those are a metastatic tumor. The big spot at the bottom is the radioisotope used for the Octrio scan in the urinary bladder. That's normal because it's excreted in the urine. And here, the little spot down in the right lower quadrant is carcinoid in the appendix, big carcinoid there. Now, I mentioned this before, but I'll emphasize again, 25% of cases will develop at some time in their life another cancer. So that always has to be watched for. And finally, treatment divides into 3 types: supportive, surgery, and anti-proliferative. That means against the growth of the tumor. They may all coincide. Different components of each may be necessary. You'll hear about new drugs today and other technologies that are fairly new. Antidiarrheal drugs come in a wide variety, but the gold standard is the somatostatin analogs in the United States. That's octreotide. And we use it, as many of you know, that's the generic name for sandostatin. Various nutritional supplements are important in appropriate cases. The same thing for electrolyte replacement and anti-ulcer medication. Surgery, there's a whole bunch of things that can be done in appropriate cases. But most important is getting a tissue confirmation of the diagnosis. Biopsy is essential, and a fine needle aspiration is not good enough. It's the safest, easiest, that's true, but it doesn't give enough information. We really want at least a core needle biopsy or even an open biopsy, especially nowadays when we can do molecular profiling analysis on a biopsy. It requires more tissue, but helps us to tell what drugs this tumor might be responsive to. We can ablate tumors by radiofrequency, and now you'll hear about the nano knife, irreversible electroporation. You'll hear that today. We can inject materials, both chemicals, particles, and radioisotopes into the liver by way of the hepatic artery to destroy the tumors internally. We can replace heart valves, which we do very often. We can relieve ascites, the collection of fluid in the belly, in various ways. We can relieve occluded channels, whether they be blood vessels or bile ducts, by stent placement. And finally, in very, very special situations, we can transplant the liver. Multitasking surgery is the best thing now when there is extensive disease. All at one operation, we can debulk tumors in the liver. This is not curative, but it certainly can prolong life and relieve symptoms. We can resect the primary tumor. We can take out the gallbladder and prevent thereby gallstones, which is a frequent side effect of chronic use of octreotide. And we can get a good specimen for studying both the molecular profile and blood vessel formation outside the human body and help in guiding treatment. Then finally, anti-proliferative treatment. We have a variety. We have biological treatment, with octreotide and alpha interferon. We have various types of radiotherapy, external beam. We have I-131, MIBG. You'll hear about that today. It's not widely used, but has effectiveness in certain cases. Yttrium-90 and now lutetium-177 systemic isotope, so-called PRRT, are very useful and just beginning to come to America. And then finally, we have two varieties of chemotherapy: the standard old-fashioned cytoreductive toxic materials, and the newer agents that are personalized and targeted towards features of any given tumor when their likelihood of being effective in a given case can be determined often by molecular profiling. So once a diagnosis is made, no treatment is not the way to go nowadays usually. Surgery can be for a cure, and at present, unfortunately, only complete resection of the tumor and even its metastases by surgery is the only avenue for a cure. But nonetheless, surgery can be palliative, and debulking can lead to improvement and prolonging life, and allow for better medical treatment. Medical treatment may be supportive, may be radiation of one of the different types I mentioned, biological treatment, or chemotherapy of the different types that have been mentioned. So in conclusion, the diagnosis and treatment of carcinoid and related NETs is not simple. It's complicated, best done by an expert. In fact, many experts, multiple disciplines, and has to be customized in each case, but then can be highly effective. Thank you.